This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we're talking about vaccines. Our guest today is Dr. Gregory A. Poland, a vaccinologist at Mayo Clinic in Rochester, Minnesota. Dr. Poland studies the immunogenetics of vaccine response in adults and children. He and his team with the Vaccine Research Group fight infectious diseases and bioterrorism through their vaccine research. Hi, Dr. Poland. Welcome to the show.
Good to be here.
Oh, we're so thrilled to have you. I personally love vaccines. I'm one of those vaccine enthusiasts. I love reading about vaccine history. One of my favorite parts of the John Adams biopic was when vaccines were being developed and Abigail Adams is administering them to her kids. I'm really into vaccines, so I'm excited about today's conversation.
I'm pretty excited about vaccines too.
We all should be, right? A lot of us wouldn't have made it to adulthood without vaccines.
That's right. I'm of an age where myself and my brother and sisters, we all had measles, mumps, rubella. Fortunately, we did not get polio that any of us know of.
For a lot of us, when we think about things like polio or measles, they almost feel like ancient history because younger generations, we were lucky to grow up without these being a part of day-to-day life.
Well, young mothers and fathers, particularly, they've never seen those diseases, so they don't have an appropriate fear. So when a pediatrician suggests they get their kids immunized, they're not very scared of them.
And they should be, because these are terrifying diseases that have killed many people, debilitated them. So it's very serious. I'm curious, Dr. Poland, how did you first get interested in vaccine work?
A couple of things happened, 3 things almost kind of in the same year. One, I got influenza A. I was doing my residency, sat down to look at a chart, and I almost couldn't keep sitting up just inside of a minute or two. And I had such severe influenza A, they had to take me by wheelchair down to my wife to take me home. Oof. And it dawned on me, wow, we have so many patients that are admitted to the hospital with influenza. So that was one. The second, in Minneapolis, where I did my residency, we had an older man slip on his porch, scraped his elbow on the concrete, and developed tetanus. Ooh. He survived, but he did not have the same level of thinking or use of his arm as he had before. So he was left with a neurologic deficit. And then third, one of my junior residents had a newborn son who developed Haemophilus influenza type B, and he is permanently deaf as a result. So I got very interested in the notion of preventing disease rather than treating reactively once disease had occurred.
That makes so much sense that you decided to work on the preventative side. So let's talk about that. How do vaccines prevent disease?
So we give vaccines in different ways. We give a portion of the virus, such as influenza or COVID, or we take the whole virus and we diminish its effectiveness, make it weaker, like measles, mumps, and rubella, or we might kill the virus or the bacteria and administer that. So all of them are an attempt to get the body's immune system to think that it's being invaded by this pathogen and produce a protective immune response. Now, some of those immune responses are lifelong. Well, I've had smallpox vaccine. Measles vaccine is the same way.
Yeah. A vaccine is essentially showing the body, here's this thing that could be a danger. And the body says, oh, thanks for letting me know about this. I'm going to build my defenses. So if I'm exposed to it beyond this very small, non-dangerous dose, the body will be able to fight it.
That's exactly right. We're training the body to recognize and respond to that invader.
Mm-hmm. Now, during COVID-19, we got to see in real time the rush to create an effective and safe vaccine, something I've never seen in my lifetime, and I found thrilling and amazing, and also very necessary, especially during the dawn of the pandemic. It was a very scary time. So, how do we go about making a vaccine? One day we're being told everything's shutting down, no planes are flying, and then within a couple of years we had a vaccine. How did that all happen?
Actually, within a handful of months. The way that that happened is that coronavirus vaccines and the mRNA technology behind the first two that were approved, that work actually started about 30 years prior. And then a SARS-CoV-1 vaccine was built when that outbreak occurred. So, scientists were ready. We had the technology. We knew how to do it.
Mm-hmm.
So it was a matter of producing the vaccine, going through huge clinical trials where scientists, regulators, public health put their lives on hold in order to get these done as thoroughly and as efficiently as possible.
So there already was some form of a coronavirus vaccine before COVID-19.
Not approved for use in humans, but in research, correct.
A lot of people are under the mistaken impression that these vaccines were rushed.
Well, is 30 years rushed? I think what they mean is that this is all new to me and it feels so new and rushed.
Yes.
But that was not true for those of us that work in vaccinology.
And what is the process of actually taking it from 30 years of research to actually turning it into this thing that gets injected into all of our arms?
So the pathogen is typically isolated from a human being. So somebody who's infected and sick with it, we might swab their throat and then take that into the laboratory, grow it in petri dishes, and understand what that virus is, and then take that vaccine discovery and development process from there.
Very sophisticated compared to the olden days. In the John Adams biopic that I referred to earlier, in order to administer vaccines, doctors would literally drive around with sick people in the backs of wagons, people with smallpox. And then when somebody said, "Hey, I want that vaccine," the doctor would cut into a boil on the sick person's body, take some of that boil and rub it into a cut on the healthy person's body, and there you go. There was your vaccine. So obviously, a very different way of doing things. Anywho, now that we've isolated the pathogen, what comes next, Dr. Poland?
Then you have to verify that the piece of the virus, let's just take COVID, the spike protein, is the one that will produce protective immunity. You don't want to produce immunity against a part of the virus that's negligible or wouldn't be something pathologic.
Mm-hmm.
And the way you do that is you test it in cells, you test it in animals, you get a sense of whether it's safe. Then you do phase 1 studies. These are studies done in 10, 20 people. If it looks safe, it produces an immune response. Then you do a phase 2 study. Now you're doing a few hundred people. And finally, you do phase 3 trials, which were done here in the US, involving over 30,000 people.
Mm-hmm.
And on the basis of that, a group of outside experts scrutinizes those data, makes a decision about whether benefits outweigh risks and what those risks are, and then it's allowed to be marketed in the US. Even after that process, we do phase 4 studies where now hundreds of thousands to millions of people have gotten the vaccine, and we search for any holes in the immunity or any rare side effects that we couldn't see when we did studies of only 30,000.
Wow. So it's an incredibly extensive process.
I mean, these are teams of people, each with distinct areas of deep content expertise, because, you want to get it right. You want to make a vaccine that's safe and effective. And People talk all the time and they have a lot of concerns about vaccine safety. But remember, for me as a vaccinologist, as somebody who develops vaccines, I get these vaccines too. So do my children and my grandchildren. I want them as safe as possible. I want it to be right. And so a great deal of labor goes into this.
So, how do vaccines work? They prevent infectious diseases by exposing the body to a non-dangerous version of the virus so that it can learn how to fight the disease and produce a protective immune response. Some vaccines can last for a lifetime, while others may need occasional boosters. To go about making a vaccine, first, we have to source the pathogen from somebody with the infection. Once the pathogen is incorporated into the vaccine, we test the vaccine in cells, then in animals, then increasingly large groups of people until millions have received it. That way, we can test for any issues or side effects. The ultimate goal is to make the vaccine as safe as possible for all people. Now that we can picture what goes into making a vaccine, let's imagine where we'd be without them. So, to underscore the importance of vaccines, Dr. Poland, I hope you'll humor me. What would a world without vaccines look like?
Well, the world would look like what it did in the past when I was a kid, or in the months before we had the COVID vaccine. What you would have is waves of infectious diseases that would cause people to miss work, cause them to miss school. A certain number, depending on the disease, of people would die. A larger number would have complications, and a much larger number would end up hospitalized. So it was extraordinarily disruptive. And for some diseases, let's take measles, fortunately rare, but 1 or 2 out of 100,000 to 1 million would develop years later. A very unusual disease called SSPE that would basically cause them to lose the ability to think. For polio, it might be paralysis. For Haemophilus influenza type B, it can be meningitis where you lose your hearing or you die or you're unable to use a limb. For mumps, it might be that you're sterile afterwards. For rubella, particularly in a pregnant woman, odds are very high she will deliver a baby with congenital defects as a result. So these are not trifling things. You hear people talk about routine childhood illnesses. Well, these were diseases that killed. These were diseases that led to profound complications. And we have these vaccines and can prevent these sorts of diseases. So you would want to think very, very carefully before you would reject a vaccine because you are now susceptible to that disease. And the people around you who might not be able to get a vaccine, let's say they're immunocompromised or couldn't respond to a vaccine, you now become a threat to them in addition to all this.
I'm so glad you brought up immunocompromised people and other people who can't get vaccinated. How does a vaccinated population protect those folks? If they can't get vaccinated, why does it matter if I'm getting vaccinated?
I'm going to simplify here for the sake of illustration, but let's take a circle and you have 100 people in that circle. In the center of that circle, let's say that it's somebody immunocompromised who can't get a live virus vaccine like measles, mumps, rubella. So they're susceptible. On top of it, they're immunocompromised. So if they get one of these diseases, it's likely to be very serious, if not life-threatening. Now, if only a handful of people around that person are immune, it's easy for the virus to get to the center of that circle. But if all of us in that circle are immune, even if we got exposed, we're not going to get infected and we can't pass it on to that immunocompromised person. So we see this all the time in the school classroom, in the workplace, in churches and synagogues. Those are essentially those circles that I'm talking about. So we protect one another. And, I'm diverging a little bit, but that's something we seem to have lost, especially during COVID in our culture. And that's the notion of we have a responsibility to one another. It's not just ourselves, but it's our family and our neighbor and our work and people in our community.
Absolutely. And for those folks who are immunocompromised or can't get vaccines for other health reasons, I'm sure most of them would love to get a vaccine, but since they can't, what can they do instead?
Even if they're immunocompromised, if it's not a live viral vaccine, there are vaccine choices that they can make and get. Inactivated vaccines, for example, or so-called subunit vaccines like COVID or influenza. But if it's a live viral vaccine, MMR is an example, then they just have to be very, very careful. Sometimes that would mean, depending on the situation, wearing a mask, staying out of crowded areas. In other cases, if we knew, let's say, smallpox, somebody got exposed to that, or in varicella or other diseases, we do have immune globulins. In other words, out of donors who agree to give blood, we harvest those antibodies out of their blood, concentrate them, and then we could give it to an immunocompromised person if they get to us in time against that disease, to give them what's called passive immunity. Their bodies didn't make that immunity. We're giving them that immunity, and it will last for a few months.
Now, we already mentioned that some people with autoimmune illnesses can't get certain vaccines. What other people might have to be more careful with vaccines? Maybe vaccines aren't the safest thing for them.
A good example would be we would not give these live, although weakened viral vaccines to somebody who had a solid organ transplant or a bone marrow transplant. We have to be very careful there. There's some vaccines we don't administer during pregnancy. Some vaccines we do give during pregnancy. So it really depends on that specific patient situation. What kinds of medical issues do they have? What kinds of medications might they be taking? Or if they're getting radiation, there are times when knowing that would say, well, we're going to delay giving this vaccine, but you are eligible for this one. So we really have to personalize that based on that medical history.
Mm-hmm. When it comes to side effects after getting a vaccine, what are some pretty common ones?
So think of the spectrum of side effects. There are those that are very common. My arm is sore. I have redness. Maybe I feel a little down and out of the weather, kind of flu-like for half a day. There's those kinds of things that happen.
I always get a sore arm after a vaccine. And
Sure.
I hear from different folks, oh, this will help. Exercise more, swing your arms around afterward, drink more water. Do any of these actually help with the soreness of the injection point?
I think very mild and short-term rubbing of the injection site is a little bit helpful. But otherwise, no, swinging your arms, more exercise, that probably is not going to help. What you can do is take something to reduce, say, local pain, muscle aches and pains, or low-grade fever, such as Tylenol. That's easy to do, easy to take. Maybe going to bed earlier. Those are transient side effects that come about because your body is producing exactly the messengers to tell the body, produce antibodies against this. So that's a successful, if you will, fooling the body into thinking that there's an infection so that it produces immunity. So it's expected. And that's one of the things that, we don't always do a good job of telling our patients, look, expect this kind of side effect. It's not dangerous. It will go away on its own. If it's more than that, if it doesn't go away, I want you to call me so that we can assess this and see if something else is going on.
So the next time I have a sore arm or feel a little bit tired after a vaccine, I'm just going to say, good job, body. You're making immunity.
Yeah.
Good job.
It doesn't mean that if you don't have side effects, you're not developing immunity, but there is some evidence that the more of those transient, local, and low-grade systemic symptoms you have, the better the immune response.
And on the very rare occasion where there are more serious side effects, what are some specific ones worthy of getting medical attention?
If you started to have numbness, if you started to have weakness, if you had any bleeding that was abnormal, if anything was a definite change in your health and a persistent over a day or two, then it would be worth getting it checked out. Let's take one that can be frightening to people, and it would frighten me, called Guillain-Barré syndrome. This is a paralysis that can result in some susceptible people after getting the flu vaccine, within 6 weeks of getting the flu vaccine. Well, that risk is about 1 in a million. The risk is far higher of that developing if you get influenza and didn't get the vaccine. So we bump right away into those kinds of things.
In a world without vaccines, our lives would constantly be disrupted by waves of infectious diseases. Illnesses that we now consider routine during childhood would regularly kill children or lead to devastating medical complications. And there'd be a resurgence of diseases we haven't seen for decades, like polio. Vaccines are meant to protect not only you, but those around you too. People who are immunocompromised, for instance, often can't receive certain vaccines. So the more of us that are protected from infection, the more we can help insulate them against exposure to a disease. If you yourself are immunocompromised, there are some things within your control. You can receive certain inactivated and subunit vaccines, wear masks, and stay out of crowded areas. You can also receive immune globulins for passive immunity. Now, let's say you've gotten a vaccine. A normal reaction might include a sore arm, redness, and or flu-like symptoms for about a half a day. But if you're feeling side effects of numbness, weakness, or have abnormal bleeding, consult with your doctor. Next, we'll ask Dr. Poland for tips on how to keep up to date with your vaccines. Let's talk about which vaccines a person should get throughout their life. You already mentioned the MMR, measles, mumps, rubella for little kids. A lot of us can't even go to school without getting those vaccines, as well as a host of other vaccines. But I have to be honest with you, as an adult, I always worry I'll forget. Am I not up to date on certain vaccines? How often do I have to get certain vaccines? Do I need to get that vaccine again? I got the first year of college. Which vaccines should all of us who are adults be checking their status on regularly and trying to stay up to date on?
You mentioned a good point. The nature of the practice of medicine should not depend on you, the patient, to think about or ask whether I should get a vaccine. Yes, do that because of the problems in the medical system, but we really ought to have a much more preventative, health-geared sense of medical practice rather than reactive sick care. So it's on us. A good physician is checking that every time they see you or when you come in for an annual exam or whatever opportunity they might have. So, think about the kinds of vaccines you should get. COVID vaccine, influenza vaccine, hepatitis vaccines, measles, mumps, rubella vaccines, vaccines against herpes zoster, which comes from chickenpox, vaccines against pneumonia, against meningitis, against polio, a new set of vaccines that we have against RSV, respiratory syncytial virus. How would you possibly expect a layperson to know that? That's my responsibility. When I agree to take care of you as a physician, I'm really saying I'm going to help you navigate the pathway or the journey to health. And let's start with the preventive things: your diet, your sleep, your seatbelt use, your vaccines, your exercise patterns, etc.
So I should talk to my doctor, and my doctor will let me know this is what it's time to get right now. It's been a long time since you've had this vaccine.
Based on your age, your medical condition, maybe your travel plans, whatever it might be. And those are unique to individuals. And so we have to personalize that advice. But maybe one easy way to say it is, whenever you're seeing your doctor, it's a good habit to say, do I need any vaccines? Can you check whether I'm up to date on my vaccines that are recommended? By asking that question, you've put it on the table.
Let's say I've moved around a lot. I have. And I've had a lot of doctors over the years. And our systems are not unified, where my doctor in this city knows what my doctor in this city does, much less the doctor that I went to that's downtown versus by my house. And so is there a risk when I say, oh, I'm not sure if I'm up to date on vaccines? Is it possible for me to then go overboard and get too many vaccines to make up for it?
It is possible.
Oh, it is.
Indeed. For example, there have been some nice papers showing that if you over-immunize against tetanus and diphtheria, you can actually increase the risk of reactions like fever, joint pain, etc. So we don't want to do that. So what do? Well, sometimes we have to make educated guesses, but again, we work hard to try to get those immunization records. More and more states do have registries that we can appeal to. We do have electronic medical records now, so we can access or query a medical record about vaccines. But when it finally comes down to it, if we don't have any of that information, because of the large margin of safety of vaccines, we would default toward, we just got to be sure you're immune against this, and we'll administer the vaccine.
Got it. So how often should I be aiming to get, let's say, that tetanus or diphtheria vaccine that you mentioned?
Typically, we say every 10 years or with a puncture injury, and we give DTaP, the acellular pertussis or whooping cough, to a woman every time she's pregnant so that she can pass those antibodies on through the placenta to the baby.
I've been asked by certain friends of mine, are you up to date on your whooping cough vaccine? Because I don't want you meeting my baby till you get one. So I have had whooping cough vaccine in my adult life also. And let's talk about some other ones that we have a certain schedule around. The ones you mentioned, every 10 years for diphtheria and tetanus. For flu and COVID, I get those every year in the fall.
Every year for those, if you're over the age of 65, then you get a COVID vaccine every 6 months.
Oh, okay.
And for some immunocompromised individuals, we would give it even more often than that.
And when people turn 50, the shingles vaccine is prescribed usually.
They can get the 2-dose shingles vaccine. They can get the vaccine against pneumococcal pneumonia also.
Okay.
It's also a time in life when we begin to ask about other things, such as prostate cancer screening, colon cancer screening. So there are other things we do in that preventive health visit.
Got it. So as we age, we'll be getting other kinds of preventative care, other kinds of vaccines that we wouldn't be getting if we were little children going to school for the first time.
I mean, a good example would be in the last year or two, we've had new vaccines against respiratory syncytial virus, RSV, very kind of like influenza. Well, everybody gets 1 dose of that at age 75 or older. They can elect to get it earlier, as early as age 60. And for one of the vaccines that's approved, even down to age 18, if they have chronic medical problems that place them at increased risk were they to get that infection.
Mm-hmm.
There are other vaccines. Let's take hepatitis B vaccine, where you'd get 3 doses and you never get it again in your life.
Oh, okay. And then something that got developed when I was just a little bit too old to get it was the HPV vaccine. Tell us about that.
So HPV stands for human papillomavirus vaccine, and it was designed to prevent genital warts and to prevent cervical cancer. So we give that to people starting at age 9. However, there is a recent recommendation where we can give that vaccine, particularly to women, as late as age 45, 46 years old.
Oh,
Yeah.
When it first came out, everyone was like, oh, it's for teenagers. You're way too old for it. But, oh, okay.
Well, we routinely gave it anywhere up to age 26, but you can even give it up to age 45.
Oh, that's great. That's fantastic to know.
Because essentially it's a sexually transmitted disease.
Mm-hmm.
So HPV and hepatitis B vaccines are our first anti-cancer vaccines.
Mm-hmm.
They prevent for hepatitis B liver cancer, for HPV, cervical, vaginal, penile, head and neck cancers. So it's a great vaccine that got developed, and yet people don't understand the importance of it.
Yeah. And I think a lot of that is just because the information we've been given has changed over the years.
The other thing is, the reason we have specialties is that the volume of medical information is so large and so constantly changing that it's hard for any one practitioner to keep up. So many of the questions, and I still get them with COVID, with RSV, there are nuances to these vaccines that many primary care physicians don't even fully realize.
Mm-hmm.
So it is important to ask. It is important to come armed with information so that you get the right vaccine at the right time for the right person.
Mm-hmm. Got it. And you mentioned that when we travel, we might need certain vaccines. What kinds of vaccines and for what kinds of countries?
Depending on where you're going, you might need typhoid vaccine. You might need cholera vaccine. You might need yellow fever vaccine. For example, I've traveled to countries where I've gotten a booster dose of polio because that country had polio. You might, if you haven't had it, need hepatitis A vaccine, Japanese encephalitis virus vaccine.
Mm-hmm.
And so we have tried for years to get travel agents and airlines to say, when somebody's traveling to these destinations, why not just put a little thing? Please ask your doctor about any travel-related vaccines you might need.
So simple and makes complete sense.
And depending on the vaccine, you might have to start anywhere from 2 to 6 weeks before travel to get that vaccine series.
Now, when we get vaccines, we oftentimes have to read one of those disclosure sheets that warns us about risk factors. Some folks get freaked out when they see mentions of symptoms or side effects. What reassurances do you have for those folks out there?
It's an interesting thing, and I've published papers about this. I absolutely believe that we should be 100% transparent about the risks and benefits of any drug, vaccine, medical procedure that we do. Here's the problem. The way they're written, it involves terminology that people are unfamiliar with, and the vast majority of people don't understand statistics and probability. So when I start saying a 1 out of 1,000 chance, they're hearing, well, if it's 1 out of 1,000, it's going to be me. And now I'm scared and I don't want to get the vaccine. So it's this balance between educating, reassuring, answering questions, and helping the patient to understand that balance of risks and benefits. For example, if I said to you, I got something you're going to love, Kristen. You're going to use this every day.
Okay, sure. What's the catch?
Well, maybe about a 10% lifetime chance of permanent disability or death. Would you do it?
10%?
Yeah, almost everybody I've asked that says, no, I wouldn't do it. And I said, oh, that's so sad because what I just described to you is the automobile in the U.S.
Oh, wow.
The point is this, they're not even aware of the risks that they're undertaking. Imagine if a car came with a form that you had to sign listing all the risks of being in a car or driving a car. You probably wouldn't do it.
Wow.
You'd be so scared.
Oh, that really puts things in perspective. If a vaccine has less than a 1 in 1,000 chance of having a side effect.
Well, think about what is the risk of having an allergic reaction to a vaccine? About 1 in a million. We don't want a 1 in a million risk to occur, but we'll have a 30 to 40% chance of getting flu this year if you don't get the vaccine. And if you get flu, you're going to miss work or school or that family wedding or that skiing vacation you wanted to go on. And there's this chance that you'll end up in the hospital, and this chance that you'll have pneumonia, and this chance that you're going to feel miserable for a couple of weeks, and this chance that you might have fatigue that lasts a month or more. Which set of risks do you want to choose?
Yeah.
There is not a risk-free option here. I wish there was. There are risks with vaccines, which fortunately are very rare. And there are risks with not getting the vaccines, which unfortunately are much more common.
Dr. Poland, this has been such an informative conversation, and there's still so much more to learn about vaccines, so much that we can't end it here. So we'll see you again in our next episode for part 2. Thank you so much.
Thank you.
When it comes to getting all your vaccines, it can be a lot to remember your vaccine history and which ones you need to get. So it's a good idea to check with your doctor whenever you go in for a routine visit. If in doubt, don't default to just getting another shot. It is possible to get over-immunized, so try to check your immunization records first. And as we get older, our vaccine needs may change. We may have to get some more frequently than before, like a COVID vaccine every 6 months for those over age 65. You might also need vaccines you've never had, like a shingles vaccine for those over 50. And if you haven't heard, you can still get the HPV vaccine until you're around age 45. Make sure to also ask your doctor about vaccines if you're traveling to a new country. And remember, the risk of an allergic reaction to a vaccine is infinitesimally small. The risk of getting flu or COVID or whatever, much, much higher. So get your shots before you get sick. Okay, that's all for this episode. But if you've got a question or topic suggestion, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. And on the next episode of Health Matters, Vaccines Part 2.
I've heard it for decades. I got the flu vaccine and I got the flu anyway. Well, yes, it protected you against infection, influenza vaccine in particular, imperfectly. But more importantly, you didn't die. You didn't end up in the hospital. You didn't end up with pneumonia. And that's what its real benefit is.
For more information on vaccines, make sure to check out Mayo Clinic's Vaccine Hub. We'll include a link in our show notes. For more Health Matters episodes and resources, head to mayoclinic.org/healthmatters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.
If you're a podcast host, listen up. This one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle. And I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.